This recording will provide additional information about coronary artery bypass graft. In terms of preoperative care, CABG surgery may be planned as an elective procedure or performed as an emergency. One potential complication of CABG is sternal wound infection. To decrease risk, have the patient shower with 4% chlorhexidine. This decreases the number of microorganisms on the skin. Surgical sites are prepared by clipping hair and applying chlorhexidine with isopropyl alcohol. In addition, IV antibiotics are administered 1 hour before the surgical procedure. Familiarize the patient and family with the cardiac surgical critical care unit and prepare them for post-op care. If the procedure is elective, demonstrate and have the patient return a demonstration of how to splint the chest incision, cough, deep breathe, and perform arm and leg exercises. Stress that the nurse must report any pain to the nursing staff. Most pain will be at the site where the vessel was harvested. Analgesics will be given to promote comfort. Coughing and deep breathing are essential to prevent pulmonary complications. Early ambulation is important to decrease the risk of venous thrombosis, and possible embolism. For traditional surgical procedures, explain that the patient will have a sternal incision, possibly a large leg incision, 1, 2, or 3 chest tubes, an indwelling urinary catheter, pacemaker wires, and hemodynamic monitoring. An endotracheal tube will be connected to a ventilator for several hours after surgery. Tell the patient and family that the patient will not be able to talk while the endotracheal tube is in place. When describing the post-op course, emphasize that close monitoring and the use of sophisticated equipment are standard treatment. Pre-op anxiety is common. In terms of the operative procedure, coronary artery bypass surgery is performed with the patient under general anesthesia for both coronary pulmonary bypass and off-pump surgery. Coronary pulmonary bypass is used to provide oxygenation, circulation, and hypothermia during induced cardiac arrest. Blood is diverted from the heart to the bypass machine where it is heparinized, oxygenated, and returned to circulation through a cannula placed in the ascending aortic arch or femoral artery. During bypass, the patient's core temperature remains between 95 and normal temperature. Although cooling decreases the rate of metabolism and demand for oxygen, keeping the heart warm decreases post-op complications that were more common when cold cardioplasia was used. The heart is perfused with a potassium solution which decreases myocardial oxygen consumption and causes the heart to stop during diastole. This process ensures a motionless operative field and prevents myocardial ischemia. Once the heart is arrested, the grafting procedure can begin. The cardioplegic solution is flushed from the heart after the procedure. The heart regains its rate and rhythm, or it may be defibrillated to return it to a normal rhythm. When the procedure is completed, the patient may be rewarmed if cold cardioplegia was used, and weaned from the bypass machine while the grafts are observed for patency and leakage. The surgeon may place atrial and ventricular pacemaker wires and mediastinal and pleural chest tubes. Finally, the surgeon closes the sternum with wire sutures. After traditional surgery, the patient is transported to a post-open heart surgery unit and undergoes mechanical ventilation for 3 to 6 hours. Be sure to use sterile technique when changing sternal or donor site dressings. Closely assess the patient for dysrhythmias. Hypoxemia and hypokalemia are frequent causes of ventricular dysrhythmias. If the patient has symptomatic bradydysrhythmias or heart block, turn on the pacemaker and adjust the pacemaker settings as prescribed. Monitor for, report, and document other complications of CABG, including fluid and electrolyte imbalances, hypotension, hypothermia, hypertension, bleeding, cardiac tamponade, decreased level of consciousness, and anginal pain. In terms of managing fluid and electrolyte imbalance, assessing fluid and electrolyte balance is a high priority in the early post-op period. Edema is common. However, decisions concerning fluid administration are made on the basis of BP, pulmonary artery wedge pressure, right arterial pressure, atrial pressure, cardiac output, cardiac index, systemic vascular resistance, blood loss, and urine output. Because the serum potassium level can fluctuate dramatically, electrolyte levels are checked frequently since imbalances can cause dysrhythmias. Potassium and magnesium depletions are common and may result from hemodilution or diuretic therapy. Hypotension is a problem because it may result in the collapse of the coronary graft. If the patient is hypovolemic, it may be appropriate to increase fluid administration or administer blood. The healthcare provider may manage a patient with volume replacement followed by vasopressor therapy to increase BP. However, if hypotension is the result of left ventricular failure, IV inotropes might be possible or might be needed. Hypothermia is a common problem after surgery. Although warm cardioplegia is now the usual operative procedure used, it's not uncommon for the body temperature to drift downward after the patient leaves the surgical suite. Monitor body temperature and institute rewarming procedures if temperature drops below 96.8. Rewarming may be accomplished with warm blankets, lights, or thermal blankets. The danger of rewarming patients too quickly is that they begin to shiver, resulting in metabolic acidosis, increased myocardial oxygen consumption, and hypoxia. To prevent shivering, rewarming should proceed at a rate no faster than 1.8 degrees Fahrenheit per hour. Hypothermia is a significant risk for the patient after CABG surgery because it promotes vasoconstriction and hypertension. After surgery, many patients experience hypertension. Hypertension is dangerous because increased pressure promotes leakage from suture lines and may cause bleeding. Bleeding after CABG surgery occurs to a limited extent in all patients. Measure mediastinal and pleural chest tube drainage at least hourly. Report drainage amounts over 150 mL per hour to the surgeon. If the patient is bleeding and the mediastinal tubes are not kept patent, fluid or blood may accumulate around the heart. The myocardium becomes compressed and cardiac tamponade results. The fluid compresses the atria and ventricles, preventing them from filling adequately, thus reducing cardiac output. Assess for, document, and report manifestations of cardiac tamponade immediately, including sudden cessation of previously heavy mediastinal drainage, Beck's triad, which includes jugular vein distension but clear lung sounds, distant muffled heart sounds, hypotension. Paucis paradoxus, BP more than 10 millimeters of mercury higher on expiration than an inspiration, an equalization of PAWP and right atrial pressure, cardiovascular collapse. Prepare the patient for echocardiogram or chest x-ray to confirm diagnosis. Pericardiocentesis, which is withdrawal of fluid from the pericardium via a large needle, may not be appropriate for tamponade after CABG because the blood in the pericardium may have clotted. The patient may also demonstrate changes in level of consciousness, which may be permanent or transient. Patients with transient neurologic deficits usually return to baseline neurologic status within 4 to 8 hours. Permanent deficits associated with an intraoperative stroke may be manifested by abnormal pupillary response, failure to awaken from anesthesia, seizures, absence of sensory or motor function. After a CABG, check the patient's neurologic status every 30 to 60 minutes until he or she has awakened from anesthesia, then check every 2 to 4 hours or per agency policy. In terms of managing pain, differentiate between sternotomy pain, which is expected after CABG, and anginal pain, which might indicate graft failure. Typical sternotomy pain is localized, does not radiate, and often becomes worse when the patient coughs or breathes deeply. They might describe the pain as sharp, aching, or burning. Pain may stimulate the sympathetic nervous system, which increases the heart rate and vascular resistance while decreasing cardiac output. Administer enough of the prescribed analgesic in adequate doses to control pain. However, during the process of weaning the patient from mechanical ventilation, it may be necessary to use short-acting analgesics and limit pain medication because of the respiratory depressant effects of analgesia. Mechanical ventilation is usually provided for 3 to 6 hours after surgery until the patient is breathing adequately and is hemodynamically stable. All CABG patients, especially those with IMA grafts, are at high risk for atelectasis, the #1 complication. Encourage them to splint, cough, turn, and deep breathe to expectorate secretions. Early ambulation after surgery is essential. 2 hours after extubation, Patients should be dangled as tolerated and turned side to side. Within 48 hours after extubation, help patients out of bed into a chair. By the first day after surgery, they should be out of bed in a chair and ambulating 25 to 100 feet 3 times per day as tolerated. Continue to monitor for decreased cardiac output, pain, dysrhythmias, decreased oxygen saturation, and infection during these activities. Many patients have supraventricular dysrhythmias, such as AFib, during the post-op period, usually on the second to third post-op day. Examiner the monitor pattern for AFib. When auscultating the heart, listen for an irregular rhythm. Sternal wound infections develop between 5 days and several weeks after surgery in a small number of patients and are responsible for increased costs and longer hospital stays. Be alert for mediastinitis, infection of the mediastinum by observing for fever continuing beyond the first 4 days after CABG, instability or bogginess of the sternum, redness, induration, swelling, and drainage from suture sites, and increased white blood cell counts. Post-pericardiotomy syndrome is a source of chest discomfort for some post-cardiac surgery patients. The syndrome is characterized by pericardial and pleural pain, pericarditis, a friction rub, elevated temperature and white blood cell count, and dysrhythmias. A minimally invasive procedure may be used for coronary artery bypass graft instead of an open chest procedure. Regardless of whether it's a traditional CABG or a minimally invasive direct coronary artery bypass is performed, the donor vessel may be obtained using endoscope rather than a large surgical incision. The radial artery or a vein in the leg may be taken with this method. Instead of a large, painful incision, the patient has 1 or 2 very small incisions in the leg or arm. This procedure has decreased the hospital length of stay, post-op complications, and pain. Monitor the neurovascular status of the donor arm of patients whose radial artery was used as a graft in CABG. Assess hand color, temperature, pulse, and cap refill every hour. In addition, check fingertips, hand, and arm for sensation and mobility at least every 4 hours. IV nitroglycerin is often given for the first 24 hours after surgery to promote vasodilation in the donor arm and therefore maintain circulation.